Afternoon, everyone. Welcome to this webinar. Today's webinar is brought to you by the Opioid Education Foundation of America, Prevent Opioid Abuse, and Fed Up. And we're so excited to have all of you with us for this important conversation. I know many of you, we met and talked at last week's RX Summit about this important issue. And we're so pleased to have Dr. Andrew Kolodny with us to really explore the issue and talk about the role the FDA plays in new testing, genetic testing rulings that have come out, and all the different aspects of the opioid crisis as it continues to evolve. And so with us, as I mentioned, our expert speaker, Dr. Andrew Kolodny, who's the medical director for Opioid Policy Research Collaborative for the Heller School of Social Policy and Management at Brandeis University, and also the president of Physicians for Responsible Opioid Prescribing. Dr. Kolodny, welcome, and thank you for joining us.
Thank you, Angela, for having me, and thank you everybody who's tuned in for this webinar. So I am going to give you a little bit of history about FDA's failures with regard to the opioid crisis, its contribution to the opioid crisis, and then I will talk at the end about a new genetic test for opioid use disorder that the FDA has just approved, and why that test is a problem, and why that test may also contribute to the opioid crisis. If you are interested in the topic of FDA and opioids, I'll put in a plug for a paper on this topic. It's a few years old now. Covers a fair amount of the history of FDA and opioids. It's not a very long paper, and you don't have to pay for it. It's not behind any paywall. So if you Google FDA opioid crisis and my last name, Kolodny, it'll probably come up pretty early on Google, and you can, again, read it. It's not behind a paywall. And the references in this paper may be helpful if you really want to do research on this topic. And if you are especially interested in this topic, you can, of course, also reach out to me. So why should we really even be concerned about FDA and opioids, considering that FDA is in the business of regulating pharmaceutical companies, and as we all know, it's illicitly synthesized opioids, especially fentanyl, are responsible for an enormous death toll right now, rather than opioids that are manufactured legally in the United States. So why should we even still care about FDA? Here's some of the most current data. You can see that for the most currently available data from FDA, it's this brown line, illicitly synthesized fentanyl, responsible for the vast majority of opioid overdose deaths. Orange is prescription opioid, which is still a substantial number of deaths. I think it's about more than 15,000, maybe closer to 18,000 Americans died from an overdose involving a prescription opioid. So there's still substantial. Heroin, as you can see, has been declining. That's because heroin on the black market has been almost completely replaced by fentanyl. But you could see, by far, it's illicitly synthesized fentanyl that accounts for the deaths. So why should we still care about FDA? Why should we still care about prescription opioids? The answer to that question may be even harder for someone to understand if you accept some popular narratives about the opioid crisis that you hear frequently today that are incorrect. For example, one of the things you'll hear frequently is that fentanyl emerged when prescription opioids had dried up, and that these so-called drug abusers all switched from the pills or switched from heroin to fentanyl. And if you sort of believe that narrative, and what goes along with it is that, prescription, when there was more prescribing of prescription opioids, we had a less severe problem. If you believe that narrative, you may be even less interested in the FDA. But much of that narrative is incorrect. part of it is correct. The switching part is correct. We do know that the vast majority of people who switched who are using fentanyl or losing their lives to fentanyl had originally been on prescription opioids, so there was a switch. But the popular narrative is that the switch occurs around 2014 when you see the dark blue heroin line going up and you see the gray fentanyl line emerging. The narrative is that the pills dried up at that point and drug users switched to the more dangerous supply, and that made the opioid crisis much worse. But that switching didn't really happen where these deaths start to go up. The switching really happened much earlier. In the very beginning of the prescription opioid crisis, young white people in the United States, young adults who became addicted to prescription opioids, either that they had used medically or non-medically, those young people were switching to heroin because it was so much cheaper. And what happens pretty steadily, not suddenly in 2014, is heroin really begins to move into regions of the country where it wasn't previously available to meet demand for it by this growing number of young people who had become addicted to prescription opioids. So the switching happens earlier than this popular narrative would suggest. The other reason why that popular narrative is incorrect is, the idea that fentanyl emerges when the pills dried up. Fentanyl emerged when we were at the peak, near the peak of opioid consumption in the United States. On this graph, you can see opioid consumption per capita in the countries that have the highest opioid consumption in the world. And of course, the United States, which is in the blue line at the top, is much higher per capita than all of the other countries. You can see from this graph that the peak years for opioid consumption in the US were around 2010 to 2014. This graph ends in 2016. I can tell you, fortunately, that prescribing of opioids in the United States has continued to come down. Unfortunately, the prescribing in these other countries you see on this graph has continued to go up, which is a whole other webinar, to discuss what's happening internationally with opioids, which is very concerning that other countries are following in our footsteps. But the point here I wanted to make is that fentanyl emerges not when the pills have dried up, but when we are at the height of opioid consumption. And the reason the United States has the most serious illicit fentanyl problem in the world is because we have the largest market for it, because about 5% of the adult population in the United States is addicted to opioids. And for the vast majority of people who became addicted to opioids post-1996, their addiction began with prescription opioids. Roughly, we have three groups of opioid addicted Americans: a younger group, 20s, 30s, 40s, who I've just described, who switched to the black market after becoming addicted to pills. We have a middle-aged group of opioid addicted Americans who became opioid addicted mostly through medical treatment. Many have been receiving long-term opioid prescriptions for chronic pain. This is a group that really hasn't been switching to heroin in large numbers and is doing a little bit better in terms of mortality since prescribing has trended in a more cautious direction. And then we have a third group of opioid addicted Americans who didn't switch to heroin or to the black market after getting addicted to pills, but were longtime heroin users. And this is a group of mostly older Black and Latino men. The emergence of fentanyl has really been having a devastating impact on group 1 and group 3. And so that's just some important epidemiology to make sense of the current trends. So let's begin to shift gears to understanding FDA's role in the opioid crisis. And to understand FDA's role, you have to understand the role that opioid manufacturers have played in causing the opioid crisis. And I think everybody on this webinar is probably aware that there have been lawsuits filed by states and counties across the country against opioid manufacturers, not just Purdue Pharma, which was the Sackler family was clever enough to put their company into bankruptcy after settling with one of the first states that sued them, Oklahoma. But there have been lawsuits against other opioid manufacturers and distributors and retailers as well. And we've seen settlements up to close to around $50 billion in settlements that are going to be paid out over many years now. So the defendants in the opioid litigation are really responsible for the green line on this graph going up, which is opioid consumption. The red line on this graph is opioid overdose deaths involving prescription opioids, and the blue line is addiction involving prescription opioids. And the case that was made in these cases is that as that green line went up, as prescribing took off in the United States, it led to an epidemic of addiction and overdose deaths. And that's why we've seen these lawsuits. That's why we've seen these settlements. So, and there's really a fourth line you could add to that graph. This is neonatal abstinence syndrome. And you could see along with the rise in overdoses and addiction, we saw a rise in neonatal abstinence syndrome or neonatal opioid withdrawal syndrome in the United States, meaning the number of infants born opioid dependent also went up almost in parallel with the rise in the prescribing. And when we talk about the opioid crisis, we're really talking about this epidemic of opioid addiction, which has had all of these health and social consequences like neonatal abstinence syndrome, like overdose deaths, like children winding up in foster care, like outbreaks of injection-related infectious diseases, impact on the workforce. That's really what the industry has been held responsible for. The fact that the opioid industry was able to engage in a multifaceted campaign that led to this public health catastrophe, the fact that it happened suggests strongly that the systems that we have in the United States that should have prevented something like this from happening failed us. And probably the system most responsible would be our system for regulating drug companies, which is where we get to the FDA. Oh, and by the way, just another quick point before I move on. As prescribing has started to come down, as you all know too well, we haven't seen addiction go away. People who became addicted are not going to get better because the prescribing goes down. And we haven't seen deaths come down. We've seen deaths go up because of illicitly synthesized fentanyl. But one sort of bright spot in this whole story is we have seen the incidence, the number of infants born opioid dependent coming down, so that a couple of years after the prescribing starts trending down, we begin to see very significant declines in the number of infants born opioid dependent. This is telling us that we're seeing fewer women of childbearing age getting newly hooked on opioids. So this is something positive that doesn't get very much attention. So where did FDA go wrong? To really understand that, you really need to know a little bit about FDA's regulatory role with regard to pharmaceutical companies. And a terrific place, if you're interested in this topic, a terrific place to learn about what FDA's role is and the laws that give it its regulatory authority. That law is the Food, Drug, and Cosmetic Act. To understand it a little better, I very highly recommend this article, which is also publicly available. You don't need a subscription to the New England Journal of Medicine to read it, and you don't have to be a physician to understand it. If you Google the title of it, Innovation, Regulation, and FDA, put in the last name of the author, Hamburg. She was the commissioner of the FDA when this piece was written. This journal article gives you a terrific summary of FDA's history with regard to its regulatory role. And it's just a terrific article. Some of you may know that I'm not a fan of Commissioner Hamburg's role as FDA commissioner. I don't think she did a very good job with regard to opioid regulation. But this is an excellent journal article to understand FDA's role. What's interesting is that Dr. Hamburg, in describing the history of FDA's regulatory role, used heroin as an example. And I have here, I just pulled some text from that journal article, which I'll read to you. Dr. Hamburg wrote, in 1902, one advertisement for a medical product claimed, no other preparation has had its therapeutic value more thoroughly defined or better established as a remedy in the treatment of coughs, bronchitis, asthma, laryngitis, pneumonia, and whooping cough. This wonder drug was heroin, a drug that made people feel better, but had an addictive potential that made its medicinal use dangerous and inappropriate. And I think it's ironic that Dr. Hamburg would use heroin as an example because it was during her term as commissioner of the FDA that she really failed to regulate drugs that are very similar to heroin. Dr. Hamburg, I would imagine, was under the impression when she wrote this that heroin's medicinal use is more dangerous than the use of oxycodone or hydrocodone or hydromorphone or oxymorphone. I think Dr. Hamburg would probably believed, as many believe, that heroin is somehow more addictive than these other commonly prescribed opioids, which is not true. In fact, a study that was performed at Columbia University where they gave experienced heroin users an opportunity to self-administer heroin versus other opioids in a controlled setting. They essentially did a blind taste test with different opioids. And in that study, the oxycodone actually beat out the heroin as having more likable effects. And so, it's not true that heroin is somehow uniquely more addictive. When we talk about many commonly prescribed opioids, we are essentially talking about heroin pills. Now, FDA's failure to regulate opioids, if you really had to point to the single greatest problem, and there are many problems, and I'll talk about a few of them, the single greatest problem was FDA's failure to enforce a rule that a drug is proven safe and effective for the conditions where it's marketed. Or in other words, that a drug maker must prove that their medicine, that the benefits of using their medicine outweigh the risks of using the medicine for the specific conditions where they will be allowed to promote the drug. Had FDA enforced that rule when, for example, Purdue Pharma introduced OxyContin, it might have told Purdue, look, the benefits of oxycodone outweigh the risks if it's prescribed to someone near the end of life with metastatic cancer, and we'll let you promote it for that condition. That would comply with federal law. But the risks of opioids far outweigh their benefits when they're prescribed for conditions like low back pain or fibromyalgia or chronic headache. So we're not going to let you promote for those conditions. Had FDA enforced that law for Purdue, and not just Purdue, but Johnson & Johnson, which was making the fentanyl patch, Duragesic, and for other opioid manufacturers that then began to introduce their opioids on the market, had those rules been enforced, I don't believe from the beginning, I don't think we would have wound up with an epidemic of opioid addiction. By 2002, it had become very clear to the FDA even that the prescribing of opioids in the United States, and again, not just OxyContin, but every opioid that was on the market, by 2002, it was clear the prescribing had taken off at a rate much greater than could have been clinically needed. If at that point, the FDA said, hey, we messed up, we should have been enforcing this law, but we're going to enforce it now. We're going to change the indication on the drugs labels so that the manufacturers will only be legally allowed to promote extended release opioids for use at the end of life. They could have done that. And had they done that, the epidemic would never have gotten as bad as it did. But the FDA actually went in the opposite direction. And this is something I'm not going to really talk in detail about now. But if you want to read the paper I mentioned at the outset, I go into a little more detail on this subject. But FDA actually went in the opposite direction. They, rather than tightening the rules, they loosened them and made it much easier for drug companies to start putting new opioids on the market. I know many of you, if you've seen DopeSec, certainly, or you may have already have known that the FDA regulator who approved the OxyContin product, Curtis Wright, would take a job shortly after with Purdue Pharma, a much higher paying job. And he wasn't the only FDA official that would go to work for Purdue. Others would become Purdue employees, like Dr. Kramer, and others would become consultants for Purdue after leaving FDA. This is a pattern we've seen, and again, not just with FDA, but with other opioid manufacturers. And that's been a very big part of this problem, the revolving door. We've also seen where the revolving door isn't just people leaving FDA to work for industry. We also see people work from industry. They go from industry to do a stint at FDA and then back to industry. The current director of the Controlled Substances Division for FDA is someone who worked for opioid manufacturers, Marta Sokolowska, and is now FDA hired her a couple of years ago to help them regulate controlled substances in the United States. We keep seeing this, and it's one of the main reasons we've had multiple failures. So, I'm explaining that FDA has allowed marketing of opioids for conditions where they're not safe and effective. I don't want you to just take my word for it that they're not safe and effective for the conditions where they've been marketed. This is a conclusion by a federal government review published in 2015 by an agency called AHRQ. And this review was repeated in 2020 with almost the same findings. In fact, the more current review had even stronger evidence against using opioids long-term. But basically, the evidence tells us that, or what we know from a review of the evidence is that evidence supporting use of opioids for chronic pain is lacking. We don't have adequate evidence that it's effective, but we do have very good evidence that it's dangerous. And the higher the dose, the more dangerous it is. Again, this should have been enough to have prevented FDA from allowing opioid makers to promote long-term use of their products. Again, it wasn't just a federal agency review. This was a CDC statement when it released its 2016 guidelines on opioid use for chronic pain, that for the vast majority of patients, the known serious and too often fatal risks far outweigh the unproven and transient benefits. One should have to go no further than this statement to recognize that manufacturers should not be allowed to promote long-term use. And this is just an example of an ad by Endo, which manufactured Opana being the one opioid that has been pulled off the market. Well, maybe heroin was another back in 1906. But FDA allowed the marketing of Opana and other opioids for chronic pain. Now, if the law requires that opioids are proven safe and effective, how have the drugs been allowed on the market? Well, you know a little bit of the story involving Purdue and Curtis Wright. We know that OxyContin and even MS-Contin was put onto the market without the adequate studies that should have been required. And there are other opioids as well that were approved without really any adequate trials. When Opana was approved, and almost every extended release opioid, actually every extended release opioid approved since Opana in 2006, has been approved using a methodology to demonstrate efficacy, which again, I don't have enough time in this webinar to explain. It is described in the paper that I opened up with. If you want to read a little bit more about it, it's called Enriched Enrollment Randomized Withdrawal. I will just say that when drug makers have tried to prove, which is the legal requirement, that their opioids are effective for chronic pain, when they try to prove that conducting a clinical trial in the way in which you would typically conduct a clinical trial, which is where you would randomly create one group to take the study drug, another group to get placebo. The study would be double-blinded, which would mean that the patients wouldn't know if they're on the placebo or the real drug, and the clinicians carrying out the study wouldn't be able to find out in the end who's on the real drug or who's on the placebo. That's called a placebo-controlled double-blind study. When the trials were done in that way, for example, when Endo did the studies on Opana using that methodology, they weren't able to show that the drug worked, that it was effective for chronic pain, because many of the people given the drug don't tolerate it, so they drop out. They don't like the effects of opioids. About half the people who take an opioid don't like the effect. And there's a good placebo response. And if you're taking, and many people with back pain, their back pain gets better at the end of the clinical trial, the placebo group generally does much better than the people who got the drug. And so a new methodology, which would make it appear as though the drug was effective, has been in use since, and that's called enriched enrollment randomized withdrawal. It's a way of conducting the study that gives the appearance of the opioid being tolerated and effective. Our current commissioner is Dr. Califf. Dr. Califf had a term, the current FDA commissioner is Dr. Califf. Dr. Califf had a term as FDA commissioner near the end of the Obama administration. For those of you who are a little familiar with some of the history here, you may recall that Commissioner Hamburg, who wrote that article that I praised, but who was not a great FDA commissioner, she left her term early, perhaps in part because of criticism over her role regulating opioids. And toward the end of the Obama administration, Dr. Califf came in. He had a pretty short stint because he was just there for a year or two, and he knew that with a new president, that he would probably not be continuing his position, because new presidents generally bring in a new commissioner. When Dr. Califf came in, he recognized this rift that had developed between the scientific community and FDA when it came to opioids. The medical community and the scientific community were aware of what I've been explaining, that opioids are really not appropriate for aggressive use outside of end-of-life care. And of course, opioids play a role for severe acute pain immediately, for example, after surgery. But the medical community was increasingly recognizing that we had been massively overprescribing and that the role of opioids clinically was very limited, but that the FDA was approving opioids when we didn't need more opioids and allowing them to be marketed for conditions where they're not appropriate. And Dr. Califf came in really understanding the issue the way most doctors and scientists understood it. And he saw that we have a problem. Unfortunately, rather than correcting some of the mistakes, maybe because he realized he didn't have enough time at FDA to really correct them, but rather than correcting these mistakes, he took an unusual step of commissioning a report from the National Academy of Sciences on FDA's regulatory role with regard to opioids. In other words, Commissioner Califf reached out to a scientific body to advise FDA on its regulatory role, which is, again, unusual because FDA, they're the regulatory experts, the National Academy of Sciences are the scientific experts, but that was the step he took. And when that report was finally written, he was no longer commissioner of FDA. Donald Trump had become elected, and Donald Trump brought in a new commissioner, Dr. Scott Gottlieb, and that's when the report came due. The report, in many ways, was a scathing indictment of FDA's past opioid decision-making, and it called on FDA to utilize a new framework for weighing risks versus benefits when deciding on approving whether or not to approve a new opioid. And it also urged the FDA to take a look at the opioids that it's approved using this new risk versus benefit analysis to see which opioids should possibly come off the market. The new risk-benefit framework that was put forward by the National Academy called for FDA to take into consideration the impact of the drug on a community and to take into consideration the fact that medicines are not always taken exactly as directed, and that all of that has to be part of the equation. When the report was released, Dr. Gottlieb, the commissioner of FDA, issued a statement endorsing the report, and in seeking removal of Opana from the market, Opana at this point had been involved in an HIV outbreak in Indiana. Opana had made, Endo had made Opana harder to crush, which was resulting in more individuals injecting it rather than snorting it. They were using a wide gauge needle, and it was contributing to an HIV outbreak. And so he sought removal of, he basically, the FDA told Endo to remove Opana from the market. Again, that's the only opioid, and we have many opioids on the market as dangerous, even more dangerous than Opana was, that FDA has not yet sought removal. When the National Academy of Sciences issued this report, urging a new risk-benefit framework, and Dr. Gottlieb endorsed the report. Myself and other advocates, including the association that represents health commissioners across the state, filed a petition with FDA, urging FDA to now use this new framework on ultra high dosage opioids. These would be opioids on the market that come in an extremely high dose. For example, the 80 milligram OxyContin tablet, which is more potent than morphine and taken as directed, 1 in the morning, 1 at night, and then it converted to a morphine equivalent dose is equivalent to 240 milligrams of morphine in 1 day by a patient who's taking it exactly as prescribed. That would be an example of an ultra high dosage opioid, a pill that comes in a dose so strong that 1 pill can result in an overdose death in a curious teenager, or certainly a toddler who puts it in their mouth. And so for these products that seem like, hey, this is low-hanging fruit, if you're going to seek removal using this new framework, these are the easy ones to go after. Dr. Gottlieb and the FDA under Donald Trump made no move on this petition. And under President Biden, the FDA commissioner, the FDA and its current commissioner has yet to make any movement, even though in the past couple of years, we have increasing evidence that high dosage prescription opioids are poisoning children. There have been large numbers of deaths in toddlers, especially, putting these pills in their mouths. And these are not pills for which the benefits would outweigh the risks. Even an individual who might need a high dose of an opioid can always take a few extra pills of a lower dosage product. Let me sort of begin to talk about this new genetic test that FDA has just approved. This is a screenshot from the website for the company that's going to be releasing this product. The product is not yet on the market, but it was approved by FDA in late December, and the company is the product may be commercially available very soon. So if you want to find out when this is going to become available, you can go to the website and join the email list. I did that myself. So I would like to know when it's going to be available. This is a test that is supposed to be ordered by a doctor when they're considering prescribing opioids for a patient. For example, a patient who may be scheduled for surgery, and let's see what your risk of getting addicted to opioids is. So let's give you this genetic test. So that's basically the idea behind the test. I will just sort of cut to the chase right now and let you know that I'll mention a little more about this, but the test does not work at all. The test cannot predict who will or will not become opioid addicted any better than a coin flip. It is a test that never should have been approved. And when it came up for a vote by an advisory committee in 2022, where the company presented the product to a committee of FDA's outside experts and where the committee voted on whether the product should be allowed on the market, they voted it down by 11-2. That's a very strong margin against putting a product on the market. And it's very unusual for FDA to approve products when they've been voted down by such a strong margin. Some of you may remember another time that FDA approved a product harmful to the opioid crisis over the objection of an advisory committee that voted the exact same way, 11-2. There was a particular opioid that was approved, and it led to an uproar. It may have even been one of the reasons why Commissioner Hamburg stepped down. If you, let's see if anyone can guess in the chat what product I'm referring to. You can type that in if you know which opioid. See if anybody gets it. It was an extended release opioid that started with a Z. Oh, somebody probably knows it, but okay. That would be Zohydro, and that also led to an uproar. So very unusual when FDA goes over the objection of a committee. So the theory behind this product is not really anything new. What the opioid industry has been saying from the very beginning of a problem with aggressive prescribing of opioids, fueling a public health problem, their message has been that there are risky people out there, but the drug itself is not inherently risky. That we have a subset of our population who, this is their argument, that they're drug abusers, that we have a subset prone or vulnerable to addiction. Those are the people we have to be careful about. We have to monitor them more closely. We have ways of identifying them, and that's the group that we have to be careful about. But for everybody else, we really don't have to be that worried. In other words, their message was that there are risky people out there, but that the opioids are not risky. This particular editorial, which I highly recommend, it was really helping debunk that whole message, really making the point that the drugs, that opioids are themselves inherently risky, that these are risky drugs, not risky patients. And the idea here, though, around the use of this test is we can now have a genetic test that helps us know who will or will not become addicted. We can, through a genetic test, identify that small subset of our population that can take that we have to be careful about, where everybody else can use aggressively. Opioids are not risky to a small subset of our population. Opioids are risky to just about anyone who takes them repeatedly. It's duration of use and dose that more than any other factor can result in addiction in almost anyone who takes the opioid repeatedly. Opioids are not like alcohol. With alcohol, most of the population can be repeatedly exposed to alcohol and does not get addicted to alcohol. There is a subset of our population that gets into serious trouble with alcohol. And although we haven't identified the genes even for alcohol use disorder, we have good evidence that alcohol use disorder runs in families and that genetics are likely to play an important role. And it sort of makes sense if most of us can drink without developing addiction to alcohol, but a subset gets into real trouble, that there's something unique about that subset that gets into trouble. Opioids are not like that. With a highly addictive drug like nicotine or oxycodone or hydrocodone or methamphetamine, with highly addictive drugs, almost anyone who's repeatedly exposed is going to be at high risk for becoming addicted, which is why the idea that there could have been a genetic test that would have helped us figure this out, find that subset that's vulnerable, really never made sense to begin with. So I mentioned a committee voted it down. Unfortunately, in December, the FDA approved the test over the objection of its advisory committee. And this is a press release that the FDA put out when it approved the test. If you read through the FDA's announcement, I just took a small screenshot of it. If you read through the FDA's announcement, not only are they announcing that they've approved the test, but they're actually touting their approval as a way of helping the opioid crisis, because, this goes along with the thinking. If you can just find out who the problem people are, then maybe we can avoid any issues. This is not a test that's going to help the opioid crisis. It's a test that will make the opioid crisis, if it's used, make it worse. So this is news that broke last week. This is covered from the Washington Post, but if you again go to Google and type in FDA opioid genetic test, you'll see quite a bit of press coverage from last week. This was coverage of 2 letters that were signed by dozens of our nation's leading geneticists, addiction professors, psychiatry professors, who wrote to the FDA, and also a second letter to CMS, the government agency that operates Medicare, a letter to FDA urging Commissioner Califf to revoke the approval, and a letter to the administrator for CMS urging her not to cover or reimburse for this test. What did the scientists say in their letter? The scientists explained that the test does not work. And not only are there potential consequences of the test, but that the test does not work at all. The FDA, if you look at its announcement along with the release of the test, you get the sense that the FDA was under the impression that AVERT-D, this genetic test, that it doesn't work very well, but that it's better than nothing. So we're approving it, but we're going to have a black box warning to warn doctors that because a patient tests positive, they might not really be positive, or if they test negative, they might not really be negative. And so the FDA seemed to be under the impression that it doesn't work very well, but it works a little bit, and so we're going to approve it. What the scientists wrote in their letter to the FDA is that you've got it wrong. This test does not work at all. That it's what the test does is it measures or detects 15 genetic markers, SNPs, that are said to be related to the risk of the genetic risk for substance use disorder. That's what the test does. And what the scientists explained in the letter is that the idea that you can select 15 genetic markers to tell you who will or will not become addicted to a drug, that is based on old thinking about genetic markers that was abandoned long ago, that science on genetics tells us that that is impossible. In fact, even utilizing millions of genetic markers, you can't predict who will or will not become addicted to an opioid in a clinically useful way, that the test does not work at all. And even the letter cited a study where a group of geneticists repeated the methodology that was used for the drug's approval process and proved that the test doesn't work. And the letter urged FDA to take the product off the market because a genetic test that leaves a clinician or a patient with the impression that they are at lower risk, or that they're not at risk for becoming addicted to opioids, a test that doesn't work but leaves people with the impression that they're less vulnerable to opioid addiction, that false sense of security can lead to overprescribing. It can lead to overconsumption. Some individuals who test negative might even think it's safe for them to use opioids recreationally, or to take the leftover pills for fun when they feel like it, because they tested negative for opioid addiction. On the flip side, patients who test positive for being at higher risk for opioid addiction are individuals who will be falsely branded as being prone to a highly stigmatized condition. This could lead to discrimination or other consequences for these individuals. And for some of these individuals who might at some point in their life benefit from the use of opioids, might be too fearful of taking an opioid. And so, the consequences of this test that does not work at all are very serious. And again, I think would make the opioid crisis worse. So I'm going to finish up here and take some questions. I believe there's going to be an email address in the chat for individuals who might be interested in getting involved in advocacy with FDA on this issue, to help advocate to keep this product, to have FDA revoke its approval, or to have CMS and other insurers not pay for this test. So please, if you are interested in getting involved in some way, please shoot an email. You may not hear back from us right away, but ultimately someone will let you know how you can be helpful in this effort. So thank you all for tuning in. Angela, do we have any
Yes.
questions?
Yeah, you know what? Thanks so much, Andrew. I mean, that was a really comprehensive presentation, but just the scariness of that genetic testing, and as you kind of summarized at the end, the idea that someone could think that it's absolutely safe to experiment in any way or finish a bottle or other scary options, right? So thank you for touching on that. We did share in the chat the link that you mentioned on people who want to get involved, as well as the Washington Post articles that you mentioned. So just wanted to make note of that. I see that there's a quick question here about the timeline for FDA to remove. I'm not sure if that's something that to remove
We
approval.
don't know. So the letters went out last week. Again, you go online, search news, and you'll see the FDA and CMS have told reporters that they're going to get back to the letter writer. So we're going to hear back from them, but we don't know when we will hear back from them. And it is very, I think this is a real test of Commissioner Califf, because he's someone with enough of a science background to recognize that this test does not work. And he's someone who comes, he's had very close industry ties over the years. I wasn't thrilled about him becoming our FDA commissioner, but he does come out of the scientific community. And if he reaches out to genetics professors, they're going to tell him it doesn't work. But for him to say, hey, we made a mistake, we shouldn't have approved this, we're going to take it off the market, that takes a lot of courage to do that. And it remains to be seen whether or not he will really be willing to do that.
Now we don't have time for many more questions, but we did get a question, obvious, that kind of goes to the mission of the Opioid Education Foundation and Prevent Opiate Abuse, which is looking at safer prescribing and looking at limiting or reducing the amount of opioids that are prescribed, keeping our patients and keeping patients and families safe. And the question is, what kind of screening tools do you recommend if something such as a genetic test isn't something that works? What kind of screening tools are there, or what other safety measures can a prescriber use, or can someone be aware of?
So whoever asked that question, thank you very much. That's a really excellent question. And I know we're running out of time, so I'm going to try to answer it very quickly. So there are no tools that you can use that allow you to predict in advance who will or will not become addicted. The screening tools there are many screening tools, or screening tools are frequently recommended in education on this topic. REMS programs recommend it, even the mandated education that for states. But this has been studied. One of the most popular screening tools is called the opioid risk tool. It was invented by Dr. Lynn Webster, a doctor who worked for the opioid industry, and it has been studied and shown not to work. So what should we do? We should not prescribe opioids unless we have to prescribe an opioid. And this times where you have to prescribe an opioid are limited to the patients really who can't take an NSAID. There are some non-steroidal anti-inflammatory drugs are as effective, even for severe pain, as opioids, but not everybody can take them. Some people, for example, have renal disease, kidney disease. There are times when they can't be prescribed and for which we need to use an opioid. When we do need to prescribe an opioid, it should be at the lowest possible dose for the shortest duration. And again, the duration is really the key to preventing opioid addiction. If somebody takes an opioid on a rare occasion, it's much less likely to result in addiction than if they're taking it for a few days in a row. And if you're taking it for a few days in a row, physiological dependence sets in, you start to feel sick without the drug. That happens immediately if you're taking it every day. So really, we have no screening instruments that work. The answer is avoid using opioids when you can.
Thanks, Andrew. And as you know, the Opioid Education Foundation and Prevent Opioid Abuse advocate for conversations between prescribers and patients and their prescribers. And we're pleased that the 21st state has signed on to require that in the state of Virginia, which just passed that last week. So getting that information out there. I know we're at the end of our time. There were a few more questions I know that were emailed over or in the chat that we weren't able to get to. So we'll look to try to get back to you and circle back. Put some information in the chat on how to continue to get involved and different ways to continue this conversation. So I want to thank everyone for joining us today for this really important conversation. And Andrew, I really appreciate you taking the time today to share all of this information. We'll send over a link to that study that that you mentioned in the post webinar email, the study in your first slide, so that everyone can read that.
Oh, great.
Yeah. So thank you again, and I wish everyone well and have a good day.
Thank you.